Welcome to the third video of a three-part series introducing evaluating psychosocial exam components. This video describes what to do when you're with a patient. It does not describe treatment though. This video will already be pretty in-depth with evaluation. Obviously, we can't go into how to treat all psychological and social components as well. Further, this doesn't go into the art of the details of examination. It guides you through the psychosocial exam components cheat sheet. To keep things organized, improving your examination skills should be an ongoing process. We're going into this form assuming you have already given the patient the FPM intake form that was thoroughly described in the second video of this three-part series. We'll start here at the top, titled Psychological Factors. All of these are knowledge problems. This is typically where education is helpful. Pain neuroscience education typically addresses problems here. We break the knowledge impairments or psychological factors into four categories. If these four main categories are addressed, then all the psychological factors will be addressed. The four are imaging, prognosis, understanding pain, and control over pain. Imaging. A patient's incorrect belief about their imaging may be preventing them from having less pain. Prognosis. If a patient believes they will only worsen, or that when they have pain they are making their problem worse, then having less pain will be quite difficult. Understanding pain. If a patient doesn't understand why they're having pain, then it leads to more pain. Control over pain. Even if you understand pain, prognosis, and what your image means, if you still don't have ways to decrease it, then it can still make you feel very powerless, which can be very worrisome. Thus, psychological factors are pretty simple to at least categorize anyway. If there is a knowledge deficit in one of these four realms, then it needs to be determined if it's affecting their recovery. And if so, it needs to be addressed. Notice I said it needs to be determined if it's affecting their recovery. People can progress without understanding pain science as well as you do. The difficulty here is identifying if the deficit is impeding progress. If it is the primary deficit, then it needs to be tackled head on. Remember, this cheat sheet can be quite helpful to review when you have a patient that isn't progressing. You can come back here and see what you're missing. One of these factors may be the most important impairment the patient has. Next is the social realm. Now this one can be quite broad. Basically anything that affects the patient's pain that isn't a knowledge or thought process issue and that isn't a biological issue, I categorize under here. If we split it up, then we must create a new, longer term than biopsychosocial model. I find it's best to use terms that we already using if possible. Other professionals use the term biopsychosocial, and it is pretty mainstream now. To communicate best with other colleagues, it's probably best to keep the term biopsychosocial, even if everything that affects a patient's pain isn't easily categorized into this term. Thus, the rest of the factors are under the social realm. This is everything that isn't a biological factor, i.e. range of motion, strength, etc., or a psychological factor, one of the four knowledge deficits that we just discussed. These are in no particular order. We'll start at the top. Too much talking about pain. You should be on the lookout for this. If the patient has 3 or more locations of pain that does not fit a common orthopedic presentation, then central sensitization inventory A should be filled out. For instance, if a person has right neck pain, right upper arm pain, and right numbness and tingling in the first and second digits, this follows a common orthopedic presentation. Obviously, we need to do a good differential diagnosis in the exam and not diagnose the patient prematurely. People should fill out the central sensitization inventory A if they have 3 areas of pain that are not a common orthopedic presentation. On the FPM intake, it just asks if the person has at least 3 areas of pain. We are not asking them to identify if their condition is a common orthopedic presentation. Thus, if they view it as one pain, then they won't mark it. If they view it as multiple pains, they will mark it. Most often, people that need to fill it out will also mark one of the other conditions that indicate a need to fill out the central sensitization inventory A, so rarely will we miss anybody. A score of 40 or more is significant and indicates central sensitization. If the score is less than 40, then the person has multiple areas of pain, but does not have central sensitization. That's a lot of talk for the category of too much talking about pain. If the person has central sensitization, then talking too much about pain isn't going to decrease central sensitivity. The next category is pain behaviors. This is sometimes challenging. I don't know that there can be any objectivity about it. You can read what types of things to look for, but a personal example I think will be most helpful. I have left knee pain when I increase my running mileage or volume of playing basketball or heavier weightlifting. Over time, it adapts. When it starts hurting, typically the first few steps after sitting are painful and stiff, so I limp a little. This is a pain behavior. Sometimes pain behaviors are adaptive, and sometimes they are maladaptive. For instance, I don't know if I could control my limp every time. However, sometimes I limp and realize that it's not hurting, and I realize I have a maladaptive pain behavior. Luckily, I have the ability to recognize it, and it is not something I've done every time I stand up for years. However, if I had done it every time I stood up for years, and I had people asking me if I was alright, then this would be much more difficult to overcome, and can lead to disability and pain. The next category is a solicitous or punishing response by a spouse or significant other. We could talk about this forever, but I'll try to keep it brief. A solicitous response is a sympathetic but maladaptive response. These are very difficult for patients to identify typically. A punishing response is also maladaptive, but much easier for a patient to identify because they don't feel like their spouse understands them and is not supportive. There are 2 questions that can help to identify a punishing response on the FPM intake form that indicate to give the spouse response inventory. You'll have to be on the lookout for solicitous responses though, and this may not be evident in the first session. To give the spouse response inventory, then you'll notice that there are 4 separate scores with this one, and no overall score. This is found on our website. I haven't seen it anywhere else. We created it based off of the information from the original article, the research article, and correspondence with the authors. Stress is the next social factor. This is a tough one to screen for. If the patient has had pain for at least 6 months, then they fill this out. The 6 months is somewhat arbitrary, but it seems that stress is more likely to be an influence that needs to be addressed if the pain is chronic rather than acute. There are a plethora of questionnaires that could be given, but the brief resilience scale is ideal for physical therapists. It is short, good psychometric properties, and the key isn't to know how much stress a person has, but how resilient they are to that stress. Less than a 3 on this is considered significant and should be treated. Anxiety has a lot of crossover with stress, but should be measured with a generalized anxiety disorder 7, known as the GAD-7. You do this if the patient over the last several months has been continually worried or anxious about a number of events or activities in their daily life. A score greater than 10 is considered positive. It's no secret that depression and pain are highly correlated. Research shows that if either depression or chronic pain improves and the other doesn't, then the one that improves regresses again. If both screening questions on the FPM intake are positive, then the Center for Epidemiological Studies depression scale is given. If the score is less or greater than 16, then the referral to a mental health professional is indicated. It is essential to know if the person in your clinic is in litigation for the complaint you are seeing them for. Normally, prior to the evaluation, it will be known if litigation is involved. However, regardless of whether you find out prior or during the evaluation, it's important to ask pointed questions. Are you concerned that if your condition improves, that you could lose money? It is essential to ask this question specifically. There is a possibility they could lie, but their answer can give you an idea of their attitude. Continue to ask questions so you have an idea of what the process of their receiving money is and what attorneys or insurance companies are involved. Here's the underlying principle. If you don't understand the process, then you haven't asked enough questions. Anger or feeling that there has been injustice causing their pain can perpetuate the pain. If they answer yes to, do you have pain that is a result of a motor vehicle accident or occupational injury on the FPM intake, then the injustice experience questionnaire is given. A score greater than 30 is considered significant. Lifestyle factors will be discussed next. This is a subset under the social impairments. You may argue about how these are categorized, but don't focus on that. These potential recovery limiting factors need to be addressed. Inadequate sleep is an absolutely crucial factor in pain. We have 2 questions on our intake form. On average, do you sleep less than 6 hours? How would you rate the quality of your sleep? Poor, fair, or good? If the patient answers yes or poor, then the patient is given Pittsburgh Sleep Quality Index score. People that most commonly need sleep addressed put 4 to 6 hours of poor sleep. Sleep apnea should also be screened for. A simple question either verbally or on the intake, with whether they have been diagnosed with this is helpful. You should also assess the Mallampati score if the patient has a grade 3 or grade 4 and have not had a sleep study, then the person needs to have one done. Ask the person if they snore. People with a grade 3 or grade 4 Mallampati often snore, but there are other reasons to snore as well. If the person snores and has not had a sleep study, this is another reason to recommend a sleep study. Discuss this with the patient and let their PCP know your findings and what you recommend. Smoking is a difficult one. Everyone knows it's not good for them. Ask if they've attempted quitting. If they would like your help, then great. If not, just recognize that this slows progress. Unless the person is planning on quitting and knowing that this slow progress will help them quit, then it may be a nocebo effect. If they're not planning on quitting, you just tell them that it makes them worse. It may be better than just not addressed if they're not in at least the contemplation stage of quitting smoking. Use of illicit drugs can exacerbate or perpetuate pain. Physical activity is such an important factor with chronic pain. Research shows that there's a U-shaped relationship with physical activity and low back pain. Moderation in all things, right? If you have greater than 100 minutes of intense physical activity per day, then you have a higher chance of having low back pain. Remember, this doesn't mean it's a cause and effect relationship, but it correlates. The person may be required to have this level of activity for their job, could be manual labor, could be a professional athlete. Thus, this may not be reasonably modified. Also, less than 90 minutes of physical activity per week correlates with low back pain. This obviously leaves a very large range that doesn't correlate with low back pain. The subjective examination will give you a good idea of this. However, the sedentary person may fool you. Some people know they are sedentary, but some people think they're active when they're not. One way I screen people for significant deconditioning is in the objective exam. I always like to watch people walk. I will have them walk about 25 feet with normal strides, then long strides, then rapidly, and then tandem walk. Then I come back to the treatment room and have them do 10 sit-to-stands. If this brief sequence wears them out or they start talking about why physical therapy is really pain and torture, I realize they are deconditioned. Sometimes they won't be out of breath though and won't complain, but the next time they come back and tell me their legs were sore for a day or two afterwards. If that amount of physical activity makes you sore at all, then deconditioning is a primary impairment. Heart rate variability, commonly known as HRV, is a crucial and often overlooked impairment in people with pain. It is associated with stress and its effect on the sympathetic nervous system. A low HRV means that the parasympathetic nervous system is inhibited and the sympathetic nervous system is likely stimulated. HRV should be measured when resting, prior to physical activity. At least 10 minutes of moderate intensity physical activity should then be performed. Moderate intensity activities vary for each individual, right? Depending on their level of conditioning. This can include cardiovascular exercise or resistance training, but should be difficult enough that they can talk but not carry on a conversation. After this activity, HRV is measured again. A normal HRV response is indicated by the SDNN score reducing by 12.6 milliseconds. This indicates an appropriate and adequate amount of exercise for this patient. We don't have better data yet with what range is acceptable. However, in our experience, if the HRV stays within 5 milliseconds, increases or drops by more than 30, then these are abnormal responses. When using HRV to assist in identifying the response to intervention, other than exercise, we look to see if the HRV is increasing. Age-dependent norms are utilized here, and in general, an increase in 30 milliseconds would be indicative of effectively suppressing the sympathetic nervous system and stimulating the parasympathetic. HeartMath is the best clinic option to use for measuring HRV because it can record data for multiple people, unlike many smartphone apps. This does require purchasing the equipment and learning how to use the software. If this is not feasible, remember, just because you're unable to measure it doesn't mean that it is an impairment, or that it's not an impairment. Nutrition is an important factor that we all know, but how do we assess it? These two questions are on the intake form. Do you regularly, most days, eat fruits and vegetables? And do you regularly, multiple days per week, eat fast food? If no to the first question about fruits and vegetables, and yes to the second question about eating fast food, nutrition needs to be addressed to determine to see if there's recommendations you need to make or refer to a registered dietitian. There are a host of nutritional deficiencies that can cause or correlate with pain. The key isn't to be an expert, but to know enough to screen for a significant impairment you can get them the help they need. Trauma may be a primary recovery limiting factor. If the patient answers yes to the question, have you experienced any trauma, that you re-experience nightmares, flashbacks, etc., then this may be significant for their pain. Closely monitor and referral may be indicated. Now that we've reviewed the psychosocial exam components cheat sheet, there's a few key things I want to review. You won't get to all these the first day. Some you will, but this is helpful to review when you have someone not progressing. You may realize there is something you haven't reviewed, and that could be a recovery limiting factor. Or you may realize that nothing on the sheet explains their pain. Maybe it's primarily a biological presentation that you've missed. The recovery limiting factors here are not all created equal. Use your judgment of what needs to be addressed first. You may look at the severity of the rate limiting factor. For example, a score of 10 on the GAD-7 is considered positive. If the person scores the maximum of 21, then this is likely very significant and may jump out more than the person mentioning that they have a few bulged discs. Thorough evaluation and treatment of psychosocial factors is not easy. This is a cheat sheet, and it's a long presentation.